Welcome to the Deep Dive. This is your Deep Dive, built specifically from the revision notes you've shared, designed to take that static information and, well, make it more dynamic.
Yeah, turn it into something you can really engage with. And today we're tackling osteochondritis dissecans, or OCD.
Right, OCD. And we're focusing entirely on pulling out the high-yield stuff you need for your MSRA revision straight from the material you've got.
Exactly. We're just using your notes as our guide. The goal is to make the key points memorable, connect the dots.
Yep, make it stick. So it's about getting that clear understanding without getting bogged down. We're diving deep into your sources.
So we'll walk through the definition first, then causes, risk factors,
Pathophysiology, how it presents clinically.
diagnosis, staging, which is crucial, and then management, prognosis, and potential complications.
Okay, let's unpack this then, starting right at the beginning. Based on your notes, what is osteochondritis dissecans?
Okay, so at its core, OCD involves the separation of a piece of bone and its overlying cartilage from the joint surface.
Right, so bone and cartilage together, separating off. And the notes classify this.
They do. They split it into juvenile and adult forms. The main difference is whether the patient's growth plates are still open or if they've closed.
Ah, okay. And that distinction is pretty important for how it behaves, right?
Absolutely.
Yeah.
Growth plate status makes a big difference. And, generally, if it's not treated, it can lead to pain, swelling, ongoing joint problems.
Yeah, makes sense. The notes mention it was a bit of a misnomer historically.
A quick mention, yeah. But the really interesting point, the high yield flag from your notes.
Let me guess, the loose bodies.
Exactly. It's highlighted as the most common cause of loose bodies in adolescent joints. That's a massive clue.
So if you see that on an X-ray or hear about locking in a teenager's knee.
OCD should definitely be high on your differential list based on this material. It's a key link to make.
Okay, moving on to causes, or etiology. Your notes seem pretty clear that the specific cause it isn't fully known.
That's right. It's a bit uncertain, no single smoking gun. But the notes do list the likely players, the contributing factors.
Which are?
Genetic factors are mentioned, so maybe some predisposition. Repetitive trauma is another big one.
Like from sports?
Often, yeah. And the third is impaired blood supply to that specific bit of bone.
So it could be a mix of things coming together, your genes, how you use the joint, and maybe a local circulation issue.
Precisely. More like a perfect storm than a simple A causes B situation.
Okay, if the exact cause is murky, what about things that clearly increase the risk? Your notes detail several risk factors.
They do. Trauma comes up again, mentioned as a factor in about half of the cases. So a specific injury can definitely kick things off or contribute.
What about who gets it? Gender.
Well, traditionally, male sex is listed as a risk factor. But importantly, the notes point out that incidence is rising in women and girls too.
So can't assume it's just boys?
Definitely not. Overuse is another big one, especially related to sports like we just touched on. Think young athletes.
Makes sense. Anything else?
Yeah, there's a mention of a familial pattern in about 10% of cases, which ties back to that possible genetic link.
Okay.
And then there are mechanical factors around the joint itself. Things like ligamentous weakness, or if the knee alignment is off.
Like knock knees or bow legs.
Exactly, genu valgum or geniverum. Even existing meniscal tears in the knee are listed. All things that could put abnormal stress on that particular spot.
Right. So we have the what's, the who, and the potential whys. Let's get into the pathophysiology. What's the step-by-step process happening inside the joint, according to your notes?
So the notes describe it starting with some kind of disruption in the subchondral bone. That's the layer right underneath the joint cartilage.
Okay. An issue in the bone first, then what?
Well, that bone disruption affects the cartilage sitting on top of it, and then, crucially, the blood supply to that specific area gets interrupted.
Ah, there's that impaired blood supply again, fitting into the sequence.
Exactly. And without good blood flow, the bone and the cartilage in that segment start to get damaged, become necrotic, essentially. Leading to fragment detachment. The damaged piece starts to separate.
The piece we mentioned right at the start.
Yep. So you end up with this avascular fragment, no blood supply made of cartilage, and the underlying bone breaking away. And these, as your notes stress, often become those loose bodies floating around.
Got it. So understanding that process bone issue, blood supply cutoff, damage, detachment, explains the loose body formation.
And why they often don't heal on their own, being avascular.
Good point. Now, if someone presents with joint pain, what else needs to be considered? The notes list some differentials, right?
Yeah. Definitely. You need to rule out other things. Your notes mention common ones like meniscal injuries or ligament tears, especially in the knee in active people.
Those are really common knee issues.
Very. Also, just general causes of joint pain need consideration.
Yeah.
But more specifically, things like osteochondral defects, the notes flag, differentiating these from OCD and subchondral cysts.
Things that might look similar on imaging.
Or present with similar symptoms, yeah.
Hmm.
Need to keep those in mind.
Okay, let's talk epidemiology. How common is this, and where does it usually pop up? What do the notes say about distribution?
Well, the notes describe it as relatively rare overall, though the exact prevalence isn't certain. But it clearly points to children and adolescents as the primary group, particularly those involved in sports.
We mentioned the gender split more common in males, but increasing in females.
Correct. And location-wise, it's overwhelmingly the knee joint. Your notes say about 75% of all cases.
And is there a hot spot within the knee?
Yes, absolutely. About 85% of knee lesions are on the medial femoral condyle. That's the inner lower part of the thigh bone. Definitely a location to remember.
Medial femoral condyle. Got it. What about other joints?
Less common, but the elbow and ankle are next on the list. It's pretty rare in the shoulder, hand, wrist, or hip, according to the notes.
And can people get it in both knees or both elbows?
Yes, bilaterality is mentioned in 20–30% of cases. So finding it on one side means you should probably check the other side too.
All right. Clinical presentation. What are the typical symptoms someone might report, and what signs might you find on examination?
So the classic symptoms listed in your notes are things like joint pain, swelling, maybe some stiffness, locking, or reduced range of motion.
And on exam?
You might find tenderness right over the affected spot, visible swelling, or that limited movement.
The notes add some extra detail here. Age range again.
Typically teenagers or early 20s,
Yeah.
but it can affect active younger kids too. And often the initial symptoms are a bit vague, just some joint pain and swelling that seems worse after activity.
That locking sounds like a key symptom, though.
It is. Locking or catching or the joint feeling like it's giving way, that often points towards a loose body being present and getting jammed.
Any other specific signs mentioned?
Yeah, the notes mention a painful clunk during knee movement, especially with lesions on the lateral femoral condyle, the outer side. Joint effusion, that swelling from fluid, is common, especially after some kind of trauma. And there's a gait change mentioned. People with medial femoral condyle lesions might walk with their tibia externally rotated. Oh, and a clinical tip from the notes.
Yes.
It says you might actually be able to feel the tender spot on the medial femoral condyle cartilage if you fully flex the patient's knee.
That's a handy tip. And the notes really emphasize early diagnosis, don't they?
Massively important. Your notes state it's key because conservative treatment can work really well, especially for those juvenile lesions where the cartilage surface is still intact. Catching it early makes a huge difference.
So you've got your clinical suspicion. How do you confirm it? What investigations do the notes recommend?
Well, it starts with the clinical evaluation, the history and exam, but imaging is definitely needed to confirm and see what's going on. Your notes list X-rays, MRI, and CT scans. Ultrasound too.
What does each show? Let's start with X-ray.
X-rays are often the first step. They might show that classic subchondral crescent sign, which indicates some separation, or you might see actual loose bodies, especially in the knee.
And the others.
Ultrasound gets a mention as potentially cost-effective and good for dynamic scanning. CT is good for pinpointing the exact size and location of the lesion.
But MRI seems key based on your notes.
It really is. MRI is highlighted because it gives you so much more detail. You can assess the bone quality, see if there's edema, look for subchondral separation, and really importantly, assess the condition of the cartilage over the lesion. It's vital for working out if the lesion is stable or unstable.
Any other imaging modality?
Scintigraphy or bone scan is mentioned. You can show if the fragment has increased metabolic activity, suggesting it might have some healing potential, which could influence treatment.
Okay, so based on that imaging, especially the MRI, your notes describe a staging system. Why bother with staging?
Staging is critical because it tells you about the stability of the lesion, and stability is the main factor driving the management decisions.
Right, so let's run through the stages as outlined in your notes. Stage I.
Stage I. You might see some thickening of the cartilage on MRI, maybe some signal changes underneath in the bone, but crucially, it's intact and stable.
Okay, Stage 2.
Stage 2. Now, the articular cartilage is breached. There's a crack, but there's still a low signal rim behind the fragment, suggesting it's held in place by fibrous tissue. Still considered stable.
Stage 3 must be where it changes.
Exactly. Stage 3. The cartilage is breached, and there are high signal changes suggesting fluid behind the fragment and maybe in the underlying bone. This indicates instability. It's loose, even if not fully detached.
And stage 4.
Stage 4 is pretty clear-cut.
Oh,
There's a loose body. The fragment is completely detached and floating in the joint. Definitely unstable.
Understanding that progression from stable to unstable based on imaging is clearly a core concept from these notes.
Absolutely. It dictates the next steps.
Which brings us to management, heavily dependent on staging and whether it's the juvenile or adult form.
Yes. Your notes outline the two main paths: conservative management or surgery.
When do you go conservative, and what does that involve according to the notes?
Conservative is typically the first approach, especially for stable lesions, those stage 1 or 2, and particularly in younger patients with open growth plates, because they have better healing potential. It involves rest, activity modification.
Taking pressure off the joint.
Exactly. Pain management, physical therapy. The notes specifically mention analgesics, anti-inflammatories, maybe using crutches to reduce load, sometimes immobilization, like bracing or even casting, though they do add a note of caution about the risks of casting.
Okay. And when does surgery come into play?
Surgery is usually considered if conservative treatment doesn't work after a decent trial, or if you've got obvious loose bodies, or if the lesion is unstable from the start. So generally, stage 3 and 4 lesions often need surgical intervention. Also, older patients or larger lesions are more likely to need surgery.
And what kind of surgical options are listed in the notes?
There's quite a range mentioned. Arthroscopic techniques are common, like drilling into the subchondral bone beneath the lesion to try and stimulate blood flow and healing. You could do debridement, cleaning up the area and trying to fix the fragment back in place with screws or pins if it's viable. Or, if it's not salvageable, simple excision, just removing the loose piece.
Okay.
Other options include curettage, scraping the base of the crater and drilling, sometimes open surgery for large loose bodies, or complex reconstructions, potentially involving bone grafting or even advanced techniques like autologous chondrocyte transplantation, growing cartilage cells in a lab and reimplanting them.
Wow, quite a spectrum of procedures depending on the situation.
Yeah, tailored to the specific lesion and patient.
So after treatment, what's the prognosis like? What do the notes say about the likely outcome?
Well, it really varies. It's definitely not a one-size-fits-all prognosis. The notes stress that factors like the lesion size, its exact location, the patient's age, that juvenile versus adult thing again, and the type of treatment all play a big role.
Who generally does best?
Younger patients, so skeletally immature, with small, stable lesions, those stage 1 or 2 juvenile ones tend to have the best outcomes. They often heal well, sometimes just with conservative measures. What about unstable lesions?
Your notes say they can sometimes heal if they're surgically stabilized, but the long-term outlook is definitely more uncertain.
And just taking out large fragments.
Yeah, the notes suggest that excising large lesions, especially if they're in a major weight-bearing area, often leads to pretty poor long-term results, like early arthritis.
But overall, the aim is positive.
Yes, the notes conclude that proper management can provide symptom relief and ideally restore normal function.
Good. Finally, let's cover complications. If OCD isn't treated properly or things don't go well, what are the risks down the line according to your notes?
Several potential issues are listed. Ongoing joint instability is one.
It makes sense there's a defect or loose body.
Right. Persistent pain is another risk. Also, progression of the cartilage damage. And the big one your notes highlight, definitely one for revision.
Let me guess, osteoarthritis.
Yep. Early onset osteoarthritis in that joint. That's a major long-term concern.
Definitely. Anything else?
Functional limitations, just not being able to use the joint normally. Recurrent joint effusions, that swelling coming back. And of course, the continued presence or formation of loose bodies.
Okay, so that covers the key complications mentioned.
Phew, okay. That was a pretty comprehensive run-through of your notes on osteochondritis dissecans. We've covered the definition, the kind of fuzzy causes, risk factors, the step-by-step pathophysiology.
How it presents, how you investigate and stage it, the different management options based on stability and age.
And then the prognosis and those potential complications, especially that risk of early OA.
It really paints a picture, doesn't it? From that initial subtle bone problem to potentially needing quite complex surgery. And it all seems to hinge on stability and healing potential.
Absolutely. And thinking about that pathophysiology, we discussed the blood supply issue.
Yeah.
It really drives home why that early diagnosis the notes keep mentioning is so important, doesn't it?
It really does. What's quite striking from the notes is that stark difference in approach and outcome between catching those stable juvenile lesions early versus dealing with unstable or adult lesions later on. It makes you think, How much does understanding that mechanism, the disrupted blood supply causing progressive avascular damage, underline the urgency? Are you racing against the clock to intervene before that tissue damage becomes totally irreversible?
That's definitely something to reflect on as you revise. A really good point.
Well, we hope this deep dive focusing just on your notes has been really useful for your MSRA prep.
Thanks so much for joining us. And if you are revising for the MSRA, do check out the resources over at passthemsra.com.
And you can also find useful materials at freemsra.com. Best of luck with all your revision.